afternoon. Wow, it's a loud microphone. I apologize if I just blew anyone's ears out. So my name is Heidi Allen, and it's my pleasure to welcome you to today's invited symposium on the Affordable Care Act 1 year later. Technically 4 years later, but 1 year after the very exciting expansions through Medicaid and the insurance exchanges. The Affordable Care Act has been one of the most misunderstood and divisive pieces of health policy legislation our country has ever seen. And it's nice 1 year later to take stock on what went well, what didn't go very well, what we can look forward to in the coming years. We live in exciting times with the Affordable Care Act, and we have a very distinguished panel of speakers today that we're going to each try to take on different elements of implementation and evaluation so that we can have a very rounded discussion at the end. Each person is going to speak for about 10 minutes. We want to keep it really short so that you have lots of time to ask questions. So we're going to ask you to hold your questions until the very end. And then we're going to have microphones in the aisles that you can come up and ask your questions of our panelists. So Sherry Gleed is Dean of New York University's Robert F. Wagner Graduate School of Public Service. She also served as the U.S. Senate confirmed Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services from 2010 to 2012, so right during the thick of implementation of the Affordable Care Act. Dr. Gleed will be speaking to the implementation at the federal level for us tonight. Aaron Ezekiel, which is, well, the only man on the panel, joined the New Mexico Office of Superintendent of Insurance as an administrative law judge, specifically assigned to conduct health insurance rate hearings and regulatory hearings related to the implementation of the Affordable Care Act. In 2012, he became the director of ACA implementation for the Superintendent of Insurance. As his full bio isn't into the program, I also wanted to note that he was previously an attorney advisor for the Social Security Administration and an assistant district attorney in I said it wrong earlier, Bernalillo County? I don't know. Sorry if you're from there. Metro Court. Judge Ezekiel will be talking about lessons learned from implementing the coverage expansions here in New Mexico. Kathy Schwartz is a professor of health policy and economics in the Department of Health Policy and Management in the Harvard School of Public Health. Dr. Schwartz will speak to the role of competition in the state marketplace exchanges and drawing from both her expertise and most recent research in this area. Bobby Wolf is the Richard A. Easterlin Professor of Health Economics in the Department of Economics, Department of Population Health Sciences, and the Lafayette School of Public Affairs at the University of Wisconsin in Madison. Dr. Wolf will talk about research findings to date and what kind of data will be needed in the future. Thank you. Please join me in welcoming our panel.
Good afternoon, everyone. So I'm here to talk about the implementation of the Affordable Care Act at the federal level, and I want to start off giving you a little bit of context on this. I actually went to Washington and worked on the Clinton Health Plan the first time around, and compared to the Clinton Health Plan, one of the things that is really astonishing about the Affordable Care Act is how much was left to regulation and implementation. The Affordable Care Act contains in it the phrase, "the Secretary shall," 1,051 times. By the time the law was actually passed, the Secretary was already behind on several important deadlines because of the delay in passage of the law. Just a month ago, CMS began implementing Section 6002 of the Affordable Care Act. You probably don't remember that section. It's the one that calls for sunshine rules on pharmaceutical company payments to physicians. So I put this forward because the scope of this law is extraordinarily broad. So that one of the challenges in implementing the law is just how much is in it, and I'll talk a little more about that in a minute. Second, of course, the law was being implemented and will continue to be implemented in a poisonous atmosphere. It led to the rise of the Tea Party. There was a threat of a government shutdown. There was a government shutdown. There was sequestration. Lots and lots of difficulties just in the political atmosphere. Third, no one anticipated that the law would roll out in the way it did, and so the implementation funding was only $1 billion, which seems like a lot of money to us, but split among agencies, and that ran out pretty fast. No funding at all for establishment of the federally facilitated exchange, which actually wound up being the main exchange for most of the country. It was expected to be a residual to only deal with a few states, wound up being really, really important. The entire regulatory structure had anticipated that the states would step up and do a lot of work that in the end they decided they were not eager to do. To put that in the face of that, in May 2010, the American Spectator ran a story that implementing the Affordable Care Act would cost $200 billion over the decade and add hundreds of thousands of bureaucrats. So if you really wanted to do this and you looked at the law, that might be very much what you thought would happen. In total, the Centers for Medicare and Medicaid Services, which is the part of HHS responsible for implementing almost the entire law, has at this point, which is now 4 years after passage, hired a total of 1,400 additional employees. Macy's hires 2,100 extra people to work the Times Square store at Christmas, to put this in context. So there's hardly any addition to the actual human capital in the department to do this work. And this August, Screaming Headlines announced that it had cost $840 million, not $200 billion, to implement the website. So there has been much less money and many fewer bureaucrats at work on this than you might reasonably have expected looking at the law. Moreover, 2 entirely new administrative entities had to be established at the federal level to implement the law. The thing that is now called the Center for Consumer Information and Insurance Oversight, CCIO, which is a completely new bureaucracy within the federal system and does a function that nobody in the federal government had ever done before, which is to regulate private insurance plans. So there was no one in the federal bureaucracy with this expertise outside of the Office of Personnel Management. You had to set up an entirely new system. And the Innovation Center, which is the other side of this, we think about the Affordable Care Act as mainly being an insurance expansion, but there's an enormous amount of it that has to do with a payment system and delivery system reform at CMS. And the Innovation Center was built from the shell of the old Medicare demonstration projects infrastructure, but brought in a lot of new people and $10 billion in funding over 10 years. So lots and lots more money, much more money going to that than to actually the implementation of the exchanges. And then finally, there was no confirmed administrator for this whole thing. You're running this enormous enterprise, and there's nobody officially in charge of it until May 15th of 2013 when Marilyn Tavenner was finally confirmed. So the implementation challenges on this were absolutely enormous. And in the context of that, almost everything, I'll come back to the almost in a minute, worked. Insurers were confronted with loss ratios that were uniform across the country, and that did not cause the insurance industry to implode, although many people had predicted that it would. Rate review, which was a new and economist-hated intervention in the law, took place and nothing terrible happened. High-risk pools were opened in all the states and actually closed in all the states afterwards or folded into the exchanges. Expansions to young adults happened without a whimper. The Medicare payment adjustments to hospitals have all taken place. Bundled payments are moving forward. Lots of delivery system reform. The marketplaces wound up getting at least a couple of things right. There are significant numbers of insurers participating in most marketplaces and more insurers participating in the marketplaces than had been anticipated. And enrollment, in the end, turned out to look really pretty good. The lowest uninsurance rate in at least 15 years of NCHS data, roughly 10 million people newly insured, which is more than the population of Switzerland. If you want to feel good about it, we insured Switzerland. And in many states, the Medicaid expansions went forward and the Innovation Center is up and running. Most of the things that were big glitches in the beginning probably don't make very much difference. Eventually, most of the software did work. Keep Your Coverage, which has been a big bane to insurance commissioners, messed things up for a year, but in another year, no one is going to remember. And some people are going to be left out of Medicaid, possibly for quite a long time, and that is, I think, a serious problem, not in the law, but in the actions of the Supreme Court. So I guess one question is, why did things go so right? I know that's not the way that you think about this. And I think actually many of the things that went right are attributable to people in this room. We actually knew a lot going into this law. There had been a lot of policy analysis done, and we knew a lot about things like price elasticities and what insurers were likely to do. CBO was unbelievably prescient. It's actually amazing to think about that they said 8 million people would enroll in the exchanges and 8 million people enrolled in the exchanges. I mean, who gets things like that right? How did we do that? They were off by about 15% on the marketplace prices, but that's actually a pretty small mistake in this context. We had navigators, and I'm going to come back to that in a minute. We don't know whether bundled payment and ACOs will work, but certainly the research infrastructure is in place. We knew a lot about characteristics of insurance markets, and after 15 years of research, no one is saying that we have the best healthcare system in the world. which is a real benefit for those of us who are working on implementation. We also got really lucky. The Great Recession, which in other ways was a disaster, suppressed medical spending, so it looked like the Affordable Care Act was actually bringing costs down. It made rate review look good. Sequestration took the pressure off the Affordable Care Act price reductions because there were bigger hits that came. Narrow networks look like they're not as bad as we thought. Everyone has high deductibles. And we actually wound up in the era of wonk journalism, so some good news stories got out. The federal marketplace rollout was terrible, but it was actually not the worst disaster of all the marketplace rollouts. So it's always nice to look at somebody else and see them being worse. Oregon, Massachusetts, and Maryland, from the federal government, we thank you. The administration made some wise decisions in implementation. Considerable flexibility on the Medicaid expansions. Just do something and we'll be happy with you. Letting the states basically go with something pretty simple on essential health benefits, which would have otherwise mired us in arguments about what ought to be covered. Leaving the small business exchanges to the end. Having a very long first enrollment period. Abandoning the Class Act. We can talk about that after. So last thing I want to talk about is why the website rollout was such a mess. Do I have 2 more minutes? Yes, okay. So I think, and this is sort of interesting to think about, the policy, the subsidy policy, the expansion was really designed to fit the budget envelope that was available. The amount of money was the thing that was fixed. And everybody was working on trying to figure out how many people can you cover given that you have just this amount of money. So the entire legislation is structured to minimize crowd out and stretch the fixed federal dollars as far as you can. So what does that do? It means that you have incredibly complicated rules for who gets into the exchanges and what coverage they get. If your income is less than 400% of poverty, you need to be given choices on the website that depend on your income, whether you're eligible for this program or not, whether you're eligible for any other program, including employer-sponsored insurance, what the benchmark second lowest cost silver plan in your rating area is, and the premiums for you or your family, which depend on age, for all the other plans in your rating area. This is a lot more than Travelocity has to do to get you from here home to New York, especially since households in this income range have very complex circumstances. Second, we had very unrealistic expectations of what could be done in a web-based program. Buying insurance is challenging even when you just have to choose the plan among the ones your employer is offering to you. We're in open enrollment right now. In fact, even in places where the exchanges worked very well from day one, like New York and California, it turns out that only about 40% of people, 40%, actually bought their insurance on the exchange by themselves. This was never going to work like Travelocity, and it was a mistake to think so. And third, government processes are really not fully aligned with the internet age. Technology firms know that you cannot test consumer-facing software in a laboratory. It's just not possible to do it. So they use slow rollout processes, beta testing, and other kinds of soft launches. We don't have a regulatory framework or a paradigm for how to do that in the federal sector. So a website is not a rocket launch. That's the way that we think about things. And the flip side is that the failure of a rocket launch, in this case the website, doesn't need to doom the entire program. So let me stop there and let other people talk.
So I don't normally talk as fast as Sherry. I want to describe what I found from a project looking at the different forms of insurer competition that happened in 6 particular states, and this is a project with Tim Jost and Mark Hall. The 6 states are California, Montana, Texas, Arkansas, Maryland, and Connecticut. They're chosen for a variety of reasons, which we can discuss if you want later. And what I want to do before I get into describing the forms of competition that we observe in these and the differences across these states, I want to start with a standard policy analysis question, which is compared to what? How should we think about the forms of competition we're observing in these 6 states compared to what? And the what is before the ACA became the law. So I just want to remind you what life was like in the individual and small group insurance markets, which are regulated at the state level. They were not competitive, and I think it's important to remember that they were not competitive either in terms of the number of insurers. If you look at the data from 2010, for example, there are 30 states that had where the largest insurer had a market share greater than 50%. The insurers and the managed care plans, I should say, I'm lumping them together as insurers, competed on the basis of using risk selection mechanisms, which I've described and other people have described in other papers. And the primary point of these risk selection mechanisms was to avoid people who they thought were going to be sicker, the classic adverse selection, because these were voluntary markets. They also use these risk selection mechanisms to control spending, so then they could predict what their premiums were going to be. Many people could not buy insurance as a result of the forms of competition by these insurers in the different markets. They either could be rejected when they applied, perhaps on the basis of their age or if they had had a pre-existing health condition, or they were offered coverage but at very high premiums, which most of us would think in this room were unaffordable. There also was a tremendous amount of confusion in these markets caused by the different insurers offering different types of plans covering different services, and so the ability of anybody to try and compare across plans and premiums was pretty limited, and I would challenge any of us in this room to do that. So the ACA marketplaces were structured to shift this kind of competitive behavior from risk selection to competition that we all hoped would be focused on providing value, where value is loosely, probably, defined as efforts, and I would put this in terms of efforts to improve operational efficiency. So if you think about investing in new software so that claims processing is faster, you could lower your costs of operating, and then offer insurance at lower premiums. And the ACA was definitely managing the competition in terms of restricting the plans so that they all had to cover the same types of benefits. It was left up to the states as to what those benefits were, but it was for the consumers to be able to compare apples to apples. So you were looking at different prices. So that is to say the bronze, silver, gold, and platinum plans covered exactly the same services in a state. They just had different amounts of cost sharing and therefore different premiums. So what happened? How did the insurance companies react to this new form of managed competition? What did they do? So if you start off at sort of a top 30,000-foot level and you look at all the different states, and you've probably read a lot of different information about this, it is definitely the case that in the states where there are more insurers competing, or in areas of the states where there are more insurers competing, the average premiums are lower compared to what people would have gotten prior to the ACA. But, and this is really important, states were permitted to create separate premium rating areas within their boundaries, even in the states that are the federally facilitated marketplaces. And with only a few state exceptions, those premium rating areas are the marketplaces. It's not the state, which is really, for those of us who are after trying to have managed competition, this is really not, I think, what most of us anticipated. The insurers have indeed shifted from using the standard risk selection mechanisms they were using before, but now they've got two mechanisms which, of course, we shouldn't have been surprised that they would use. One, and both of these mechanisms are intended to restrain medical spending by the people who actually enroll in their plans. So one is higher patient cost sharing, and the second is a limited provider networks, both of which, these two different mechanisms, had become much bigger deals in the private sector, particularly among large employers, during the years of 2010, 11, 12, but when the law was passed, it wasn't something that people were clearly seeing on the horizon. There are many more plan options facing people purchasing insurance in these marketplaces now. On the average number in 2014 was 54. None of us in this room face that many choices when we're trying to find a health insurance plan. When one maps these two mechanisms of either having increased cost sharing or limited provider networks onto these premium rating areas, it's really clear that in 2014, not only are there differences in the forms of competition that these carriers, these insurance companies are using, but there are differences within states that are really important to be looking at. So if you think sort of in a topography, think about a map of any state where there are some mountains, there may be some hills, there may be some flat areas along an ocean, there may be a river. You have to be thinking this way in terms of what kind of competition is going on in different parts of the state. Let me give you a quick example. Texas has 254 counties. They are set up in 26 premium rating areas. 187 counties spread throughout the state of Texas are in the 26th rating area. And the choices in those different counties differ even across those counties. So for example, Austin, which has 5 counties, there's a total of 1.7 million people, 7 different insurance companies in 2014 offering 80 different plans. 50 of them are HMOs, 30 are PPOs. The PPO structure in Texas allows you to create these narrow networks because they're not regulated like the HMOs. But in premium rating area 12, which is Webb County, it's the 6th largest geographic area in Texas. It has a population a little over 250,000. There are only 2 insurance companies offering plans. There are 20 total plans, 18 of which are Blue Cross Blue Shield. 12 of those are these PPO narrow network provider plans, 6 are HMOs, and Molina is the other insurance company. It is only offering 1 plan at the silver level and 1 at the gold level. So this gives you a sense of how different things are. We think that you can pretty much characterize these different competitive strategies by looking at the different states in terms of what's going on given their own regulations that they may have put in place or not. So one set of strategies are for states where the insurers can compete by offering many different variations of the cost sharing. This is especially true for the bronze and silver plans. And pretty much there are no plans in those states with these narrow provider networks. They have really focused on doing different cost sharing, and that's been the way they were before. A second type are where the states are really restricted to having a small number of plans at each metal level and to having very similar cost sharing arrangements. And the results there is that you see much more competition in terms of these restricted or more narrow provider network plans. And then the third is really a hybrid where you can see some of each depending on which part of the state you want to look at. And of course, these forms of competition are not random. We can talk about this more later. But not surprisingly, they're related to whether a part of a state is sparsely populated or not, whether parts of a state have a high percentage of people in poverty or without insurance. And that really, I think, is telling at these different premium rating areas. So what makes me excited about this? I am, after all, an economist. I think it's great that these marketplaces are very competitive. The fact that a month ago, more than 70 new insurers are, well, actually they get double counted, but still more insurers are coming into these marketplaces. And in particular, that includes 3 big national carriers that did not participate in 2014. They clearly see an opportunity for making money. The insurance companies want these marketplaces to work. I think that's a great thing, especially given that the Supreme Court is going to take this case. But I am very concerned about the fact that the potential for risk selection is still here. And that's something that I have been worried about, in terms of the pre-ACA marketplaces for at least the last 20 years, and I am very worried about it here. I think that some of these insurance companies are deliberately staying out of different market premium rating areas, and the way they're using either these PPO types of plans to restrict the amount of medical care that somebody can have, or using very high cost sharing is quite deliberate. So this is a very exciting time to be watching what's going on, and I'm out of time. So.
Hi, my name is Aaron Ezekiel. I'm the outlier on this panel in several ways, some of them obvious. The one, perhaps the most significant way, is that I am at work on implementing this in a state here in New Mexico. And there are a couple of things that have been said that I want to just address, and then I might rant a little bit about how difficult this law is to implement. One of the things that has made a very big difference in our state in terms of actually having competition, interestingly enough, is our State Freedom of Information Act. It's called the Inspection of Public Records Act, and we just happen to have an expedited process for people who are willing to drive all the way to Santa Fe, about an hour from here, and walk into the building where we are and sit in front of a computer terminal and look at a lovely national database called SURF, which probably most of you have never seen, but it's the system for, I forget what the E is, but it's for rate-informed filing. Essentially, all rate-informed filings for all states in all forms of insurance go into that. And when we told insurers that they all had to file at the same time, and then they were going to have another pass to do revisions, they all wanted to see, they wanted to keep their own filing secret, of course, but they wanted to see everyone else's. And interestingly enough, we decided not to let them keep theirs secret, and they all showed up. Most of the press didn't bother. Most of the public advocacy groups didn't bother. But they all showed up, and they looked at each other's numbers, and by God, I think 3 out of 5 came down significantly in year one. And it was it was a small group. We had a number of insurers that did not participate, and we created an environment that locked them out. We created a 2-year lockout. We said, you come in the first year, and you're in the second year. You don't come in the first year, you wait till the third year. And we have had several insurers very upset with that and desperately trying to influence us to come in the second year because they had changed their mind. They decided they wanted to grow. The other thing that happened out of this law that I think was very interesting is that the mantle of the reputation that the Blues once had as the nonprofit with the interests of the community at heart, which is a reputation that continues long after the reality has changed, that mantle is in the process of passing, I think. Pardon me, I'm going to try a different position for this so that it's not quite so nasty. That mantle is in the process of passing to what are misnamed the co-ops, the consumer-owned and operated plans. And I think within the next year or two, it will begin to become obvious that that's the case, which also means that during the next year or two, I think it's likely that the Blues will do their very best to kill off the co-ops. They're certainly trying. But there have been some steps taken that I think are likely to encourage the co-ops to survive. And I think that could be very important and extremely valuable. How much real influence consumers are going to have in those entities is pretty questionable to me. It's not clear to me at all that they, in fact, are really going to have very much meaningful input, but at least there's an attempt in that direction. And given the abject game playing and theft and ugliness that's gone on with the Blues as they've been transitioned to for-profit entities over the last several years, or to things that are technically nonprofit or technically member-owned, while they seem to be really under the control of, the top management. It gives me a little bit of hope. This law has also generated a really interesting conflict between the federal and the state bureaucracies. I'm not going to get into too much detail about the wonders of negative preemption, but we in theory have control. We have plenary authority over the insurance industry. We have lots and lots of things where we're supposed to be able to tell them what's going to happen. And we've had fascinating conversations with federal officials who've found a phrase in the law that they thought gave them authority to do this or that, and we haven't ended up in court over it, but I think probably eventually there will be a lovely lawsuit about that. But in essence, we have watched lots of people worrying about things that, some of them seem to be problems to us, some of them seem to be a tempest in a teapot, and, politely calling us up one day to tell us that, well, they were going to do X, Y, Z, and we say, do you really want to destroy the entire edifice of state regulation of insurance? Have at it. But it's been very interesting in that regard. I would say that, and we're in an unusual state here. This was one of the first states with Republican governance at the gubernatorial level to, in fact, move to expand Medicaid and to go forward with a state exchange. And quite a number have followed along, although certainly not all of them. later down the road. But that has not meant that the various administration appointees in our state were necessarily in favor of doing those things, although the governor mandated them. You'd think that they'd all fall in line. It's not at all been that way. It's been a continuous fight from day one to actually implement something that in fact worked. And whether it works or not, I suppose, is still a significant question. And, we're about, a week out now from the second round of open enrollment. The first round was truly a disaster from the point of view of our state. We had a state exchange that was only running the small business exchange. We had gone to the federal exchange for the individual plans because we simply couldn't be ready in time. And so we suddenly found ourselves with a great marketing plan that we couldn't do anything with for 75 days. And we nevertheless ended up with a very large number of people enrolled in Medicaid. That was the real success. And much of that, actually, interestingly enough, had to do with the marketing and outreach from our insurance exchange, because much of that turned out to really be directed into things like federally qualified health centers, where overwhelmingly their population was Medicaid eligible. So probably 70% of the outreach from the exchange enrolled people in Medicaid. And we consider that a success. We're pretty happy with that. And this is a state that had a quarter of its population roughly on Medicaid before the Affordable Care Act, and we're probably going to get somewhere up close to 40, 45% ultimately. And we got to about half of what we would have hoped for enrollments on exchange for individual plans and small group plans. Interestingly enough, we had something like 10 times that number enroll in small group plans and actually large group plans that were based on the same small group plan models outside of the exchange. We had, a few hundred in the exchange for small group and 15,000 outside because the exchange for small groups was too complicated. It was simply unbelievably complicated, and both the agents and the business owners simply walked away, threw up their hands, walked away from it, and said, just find me something. And what they found was, in fact, the same plans, just without all of the employee choice bits and pieces and that sort of nonsense. I'm going to take the last minute, and I'm just going to politely rant to say this is the result of the usual kind of terrifically ill-advised political compromise, but that you can't do much about. The reality is that if you want to pass any law, this was the best you were going to get. But it's designed to be complicated. It's designed to make it hard to implement. It's designed to make people who fall under it feel badly about the law, about the plans, about the exchange, about the terrible number of bureaucrats involved. It is simply designed to be complicated and to be demeaning. And it is typical of what happens to social programs essentially throughout the last 75 years. And I don't have any solutions to that, and I wish I did. I'm done.
Well, I'm going to talk about what we have learned, what researchers have done to look at the reduction of the number that are uninsured, improving access to health care, whether we've seen any effects on what I see as the ultimate goal, health, and also to look at some of the broader outcomes, such as effects on labor force participation and even on marriage. A number of you who are sitting here in this room have contributed to this. Rather than using names of people who have done research in my now about 9 minutes, I'm going to talk about the research in terms of the findings and the data sets that have been used, a little bit about techniques. So I apologize to all of you, but I'm not discriminating. I'm not going to mention any of you. So when we talk about research, I'm going to divide it into research that has looked at what's called dependent coverage, the expansion that allowed young people to stay on their parents' coverage through age 25. And that went into effect in 2010. It has the nice feature that it's relatively easy to compare this age group to those just slightly above, like 26, 27, and 28-year-olds, and even for some people who've studied the slightly younger group up through age 18. Then I'm also going to talk briefly about what we've learned in essentially the first 3 quarters of a year in which we have implemented the major provisions to increase coverage for the broader population of individuals up through age 64. So when we look in terms of coverage and look at coverage in terms of dependents, what we generally see is a clear increase. And in the first year, we saw an increase of something like 4.5 percentage points, a larger increase in terms of males and females, but both substantial and significant, a larger increase for non-Hispanic whites than for minority groups, and this is all using the American Community Survey. Other researchers have used the CPS and finds comparable types of coverage, learned a little bit more detail in the sense that what they find is that parental coverage is up about 8%, while coverage that other private that individuals of this age group had was down about 4 to 5%. So a shift in terms of the source of coverage and an increase of perhaps 4%. What we've also learned using either the Commonwealth Tracking Survey or some other surveys is that most of those gaining coverage are people with higher income. And that's not surprising because those are the people who have parents who have private coverage. So if we look, we find that most of those gaining coverage were above about 150% of the federal poverty line, and that there were big increases in those who were covered who were not married, who were not students, and again, who were males. If we shift and look at who's covered from the broader ACA, what we find, and Sherry mentioned this initially, is about 10 million people have gained coverage since the start of the major provisions of the ACA. If we look at who they are, in this case what we find is that it's more likely to be the working poor or people who have lower incomes. So quite different than the population that gained coverage through the dependent coverage. The individuals living in states that have Medicaid expansions, that's really where we find the much larger expansions in terms of coverage. And according to recent research using the Health Reform Monitoring Survey, that if we look at the source of coverage, it's approximately a third from employer-sponsored insurance, just under 40% from Medicaid, and about 20% for non-group coverage. So we do have a picture. It's a pretty consistent picture that's evolved in who has been gaining. So far, we've not taken advantage, and researchers have not looked at some of the major differences that you've heard about, some of the things that, for example, Kathy was just talking about in terms of how individuals would be influenced by the different kinds of packages offered and how well the insurance market worked. We know most about coverage. We know less about the other outcomes of interest. But we do know some things in terms of access to care. So if we turn and look at the people who gain coverage through the dependent population, people have used essentially 4 sources of data. They've used Burfus, and here they find that if you look at the access of individuals 23 to 25, that they've increased the probability of having a primary care physician, a goal that many have had, that there was a decrease in the probability of foregoing care due to costs of something like 2.5 percentage points, but perhaps surprising, a decreased probability of having a flu vaccine by about 2.5 percentage points as well. Perhaps an example of ex-ante moral hazard. You're now covered in case you're ill. Using administrative records on 3 states, there's some evidence of a decreased emergency room use of the newly insured, particularly amongst females and African Americans. Researchers using the National Health Insurance Survey have found a reduction in those delaying care or not receiving care due to costs, and have also looked at individuals who are covered under the requirement that people could not be turned away because of a pre-existing condition. And the only evidence that I know has found that amongst adolescents, those with a chronic condition now see a decrease in delayed care or care foregone due to cost. The last population that's really been studied has researchers used the National Survey of Drug Use and Health. It's probably the only survey we have that's enough detail to look at mental health treatment as well as substance abuse, with some suggestion that with the expansion of coverage, there is now a greater use of mental health treatment, but no evidence at all in terms of substance abuse. In terms of access to care more generally, for the more recent expansions, what researchers have found using things like the Commonwealth Fund Tracking Survey or the Gallup poll is some suggestion that adults newly insured report that they are using care, and that nearly 2/3 of them have said that they would not have yet accessed such care before they had insurance coverage. There's some suggestion that there's an increase in the likelihood of having a personal physician and a decrease in those who report they're unable to afford medical care. If we look at health, we really know very little. And perhaps that's not surprising because it's likely to take longer. But still, starting in 2010, we had an expansion to young adults. So as I read the literature, what I have found is that using BRFIS, researchers have found a small increase in those who self-report having excellent health amongst those 23 to 25, that researchers using the CPS found that people reported better self-reported health again for the 19 to 25-year-olds, and that using MEPS, there's an improvement in the mental health, particularly for young women, and some suggestion, again, of improvements in physical health, in this case, for men. But again, we know very little, and we know nothing that links prior health in terms of people who had particular health problems or had pre-existing conditions in terms of the influence of the ACA. Very briefly, people have been researching the effect on labor force participation, and here my best description of it is the results are mixed. If you have a result you'd like, there's probably a study that finds that result. So people have been very creative. A study uses tax data, and using tax data to try to identify those young people whose parents, in fact, do have coverage, so they could have an expansion. That study finds no effect in terms of employment, the type of job, or hours worked. People who have used the CPS have found a shift to part-time employment and a shift away from four-year private colleges. But people who are using SIP find instead that there is an increase in full-time students. So you get a little bit of gist that it's early on, and it really does somewhat depend on the sample that is being studied. In contrast, the few studies that have looked at the influence on marriage rates consistently find a reduction in the probability that individuals are likely to get married amongst young adults. So that does seem to be consistent. But there's nothing on the change in the days of work missed due to illness, and we know very little about exactly who is likely to be influenced. I'm out of time. I'm just going to comment that for the ACA more general, we seem to find a suggestion of a small increase in probably involuntary part-time work. But we don't, again, know much detail in terms of who has been influenced and whether this is likely to be a major issue or it's more of a sort of transitional problem as the different opportunities for coverage come into effect. Thank you.
That was an excellent panel, no? So my understanding is that there are going to be microphones set up here, or we're going to have people going around the room with microphones. So I'm going to get the panel started while you think of your brilliant questions, and remember that you are being webcast, and so be sure and turn and wave to all your friends and family around the world who I'm sure are watching this right now. So I'll start the question with the fact that it's been a very interesting week for those of us who study health policy. We had an election on Tuesday, and the Senate is no longer in the hands of the Democrats. And so this opens up some possibility that they will use the same trick the Democrats did of the reconciliation process to try to make some amendments to the Affordable Care Act. And so I'd be interested to hear what our panelists think might be likely targets for these amendments. And I'm also interested to hear any opinions they have about the Supreme Court's decision to take up the federal subsidies. And you can all take notes here right now to see who was right. And we can come back here next year for ACA 2 years later. And then we'll invite back the people who were right, and the people who weren't can sit in the audience. So.
Who wants to go first? I don't know. So predicting what the Supreme Court will do is well beyond my capacity. We don't know, and we will never know whether the decision to take the case. For those of you who don't know, today the Supreme Court decided to take the case of King versus Burwell, which is a case challenging whether the refundable tax credits, which are the main impetus for the coverage expansion, are available in states that did not set up their own state exchanges. I think New Mexico is safe. But many states did not set up their own exchanges, and it's not clear what will happen to those subsidies. So the Supreme Court agreed to take the case, which means that at least 4 justices voted in favor of taking the case. If it was 5, that's very bad news. If it was 4, we don't know what happens. It will be very interesting if the Supreme Court decides that the subsidies are not available in states without exchanges, because it will put the governors of states that decided not to open exchanges in a very awkward position. They either have to pass a one-line piece of legislation that says, we hereby declare that the federal exchange is our state exchange, and therefore our residents can get these substantial tax credits at no cost to the state because they're entirely federal tax credits, or they can say no, which will mean that a bunch of people in their state will lose insurance, actually many, many people, because the insurance reforms will remain in effect. So not only will the people who had tax credits lose their coverage, but there will be adverse selection spirals in all those states. So it's not a pretty sight. But I don't know what will happen. In terms of the Senate, I think there are 2 big issues that are surely on the table. One is the medical device tax, which is a nice example of how lobbying is really, really effective if you are well set up. There is no other reason why it should be the medical device tax among all the different provisions of the Affordable Care Act that would be so susceptible to being overturned. And the second thing is the employer mandate. The Obama administration has delayed implementation of the employer mandate, which actually makes the involuntary part-time work thing even more bizarre. The House Republicans have been suing the Obama administration for failing to implement the employer mandate, but it's likely that now that they have control of both the House and the Senate, they will eliminate the employer mandate altogether. Those seem like the most likely low-hanging fruit. Neither of those changes would make a big difference. They would be not good, but they would not be hugely awful. You can say that.
So I just would make the following comment, that if you look at evidence, and some of the evidence I did not include was what's happened to hospitals. So the proportion of hospital care that is now uncompensated has clearly gone down. So hospitals have gained, clearly, from the ACA. Insurance companies clearly have gained because of the ACA. A large number of individuals have gained because of the ACA, with relatively few people that we can identify who actually can point to something that has negatively affected them. So regardless of sort of these decisions, it seems like there's a large group who will lobby to maintain provisions of the ACA.
We have people who have questions ready? Want to raise your hand? If you don't do it, I will answer. I'll ask all the questions because I made a list. Here's your chance. Anybody? Okay. So another question I had of this panel is, what do you think is going to happen come April when the tax subsidies go through reconciliation and people go to their accountant and find out whether they have won or lost in terms of the overestimating or underestimating of the subsidies? Both, do you have any sense of where this might land? Probably Sherry, you might know most about this. And then what do you think the political fallout will be if a bunch of Americans go and find out they owe more money than they anticipated?
So I don't have a clue. I don't think anybody really knows how many people may have gotten essentially too much money because their income rose during 2014 relative to what was anticipated, and therefore what their tax credit was that they received. For sure, we know that a lot of people chose not to enroll in 2014 because they were worried that there would be this clawback, because that's being called clawback, of the money that they might be overpaid in terms of this tax credit. John Graves and I wrote a paper that was published this past June on the Health Affairs website, pointing out that if the federal government were to move the open enrollment period so that it really overlapped with tax season, people would get a much more accurate sense of what their income is likely to be in, say, 2015. And they would also know exactly how much they were getting back in the form of the Earned Income Tax Credit and any other tax refunds they were due, so they could probably make a much more informed choice about which of the different health plans they might want to choose from, so that they would know what their net premium was likely to be. And they might decide that they didn't need to take all of the tax credit for the premium subsidy at that point. They could sort of hold off to see whether their income might rise during 2015. It's very funny to me that I've gotten interest about this proposal from various people, but not one word from HHS, although I have students that work there this summer and who talked about the fact that it was being talked about. So my presumption was that, quite rightly, the administration wanted to stay far away from this whole idea before the election. And so then the next question is, if Congress, if the Senate decides that it wants to repeal parts of the Affordable Care Act, will the administration start talking about, let's fix some things? And this would be one thing that would be, I think, a big move forward in terms of moving this open enrollment season away from the holiday season when people are already very stressed about money and thinking about a tremendous number of choices. None of us have to face those choices that people choosing health plans do.
A question over here. I don't know where the mic went.
No, you need the mic.
You need the mic
because of the webcast.
So my question is for Sherry and anyone else who is knowledgeable about this and ready to answer. It's to do with the fact that the subsidies, both for the premiums and for the cost sharing, are well, the premiums in particular based on the second cheapest silver plan, and that therefore people who learned what their out-of-pocket payments based on the subsidies were before, what's the second cheapest silver plan changes, all their options, all their subsidies change. And so my question is twofold. Just what is happening in terms of dealing with that and making that clear on the ground, and what would be the best way to deal with it?
So first of all, I should say I have nothing to do with this anymore. You can complain about Wagner, but you can't complain. I'm out of it. But I think there is an effort to encourage, there are sort of two countervailing forces here. One is to try and make enrollment as easy as possible for people. So there is auto-enrollment back into your plan if you don't make a choice. And that's probably the right thing to do because there are a lot of people who are not going to make a choice, and what are you going to do with them? There's also an effort to educate people to have a look and see what the plans are. Whether people will do that or not, I don't know. The Kaiser Family Foundation has been doing some work on how many places the Silver Plan will actually change. Some places it's a big deal, many places it's not a big deal. So I think this is really one of those trade-offs that you sort of have to decide what you want to do with, because giving up on auto-enrollment would not, I think, be the right thing either. You don't really want to force people to make these choices every year.
The role of the assisters is really important here. People just don't understand enough about how to think about their future out-of-pocket costs and whether or not they're likely to get sick. What does it mean to choose a low premium plan? But that means you're at risk for higher cost sharing. And it's very clear from what we know, a lot of which is this sort of qualitative interview stuff, that when you have an assister who spends time with somebody and sort of asks questions about what kinds of risky things make you very uncomfortable, what kinds of things don't, that then people choose a plan. And when you have somebody else who sits there and says, this plan, this is the best one for you, they walk out. They don't finish. So the states where in 2014, the states that put a lot of money and effort into helping people understand choices had higher enrollments. And the states that really said, back off, we're not doing anything, that's where you've got problems. So the question is, what's going to happen to them in 2015?
I have a question. If I were in a cocoon and hadn't listened to any of the media or political coverage of this and just heard this session, I would have guessed that the popular approval of the Affordable Care Act was maybe 60 to 40, something like that. Bobby had a long list of gainers from this thing and was hard-pressed to find a loser. And yet, the polls are, 42 to 58, and they've been constant at that for some time. Would any of you like to comment on this apparent disconnect and maybe have some suggest if the real issue is perception of reality, what to do about it? Thank you.
Do you want me to do it? You want to do it? Yeah.
I think in many ways this goes back to exactly what I was referring to, which is that despite lots of pretty positive things, and including some that have not even been touched on here. This is, for example, the largest economic development program bill that's happened since the 2008 bailouts, which only went to giant corporations. And this one actually gets out to people who provide health care. But aside from that, it has been incredibly complex, incredibly invasive. It does all those things that make people hate government programs, and that are very well designed into almost all of them, after Social Security. And anyone who's ever had a kid in college and has been through the student financial aid system, this is that on steroids. And so it's hardly surprising that people are offended and hate that about it. I think, we hear, my God, New Mexico, you get the extra fun of, we've got a 10% Native American population, which has a completely different set of rules that essentially no one in the healthcare system understands, and which also does a wonderfully nice job of creating division, along ethnic and racial lines. So I don't find those numbers surprising at all. I give it 5 years, though.
I'm actually going to jump in here because I have a mic by me. Nobody's fast enough to stop me. So my dad is a lifelong Republican and lives in Idaho. And we've been talking about the Affordable Care Act some. And what he likes to say to me is, what you don't know about Obamacare. And I think, if I don't know more than you, I'm in so much trouble since that's what I study. But fair enough. So he called me and said, I'd really like to get insurance. And, he lost his business in 2009, the recession, had to lay off all of his employees, and has been uninsured since then. And so I said, okay, I'll help you. He sent me all this information. We went back and forth. And I told him that I wasn't going to hit the send button until he let me take a picture of him with a sign that said, I love Obamacare, and put it online. And he was going to go for it, right? He was actually like, fine, I hate, whatever. If I get insurance, it'll be worth it. And he was saying things like, this is actually the most I think that I've ever kind of liked something that a Democrat has done. But then I found out that he actually didn't make enough money to qualify for the exchange, and he's only Medicaid eligible, and he lives in Idaho. Idaho didn't expand. So when I told him that he actually wasn't going to be able to get, insured, his response to me was, well, it just goes to show you with the Democrats that they don't care about the working people. They don't care about us. We work our whole lives, we pay taxes, and then they're going to give insurance to people that make more money, and they're just going to let me die. I hope I make it to Social Security, so I can get on Medicare. And I thought, that he watches Fox News all the time, yet he is still so misinformed about how this works. I know. Everyone's like laughing, like, is that shocking? I don't know. But yeah, so I think that's a big problem too, is that it's so complicated and so many moving actors who people are not paying attention to make policy changes, and nobody really knows who to blame when things don't work, and they don't know who to feel good about when they do work. And I think that's the problem. That's my opinion.
Carrying on that theme, I think one of the central things about the Affordable Care Act is there's so many things people don't know and can't possibly know. But another dynamic is one you've already talked about, which is it's a mingling of a public policy action with a set of market forces already underway. And Kathy, as you mentioned, I think the narrow markets and higher deductibles and cost sharing are all part of the picture. It was going to happen anyway. We're seeing it in our own employers as we're advising what they're doing. But it does bring me back to one thing that I think all of us were, or many of us were surprised about, is that high level of the deductibles that people are able to get in these plans. And for a lot of the people who are being subsidized because of their relatively modest income to buy insurance, they see those deductibles and they don't really have something that many in the room would describe as affordable health care because the deductibles are so significant. One, are you surprised by the level of the deductibles? And two, what do you think the long-term dynamics will be in response to the law as people encounter that when they have serious medical conditions?
So that's a great question, especially since I work for a university where the faculty are furious right now about some changes. I think that it is important to realize that in many states where the individual insurance market or the small group insurance markets, where there weren't many insurers competing, it was very common to find high deductible plans. So for example, in Wyoming or Montana, if you were buying a family policy, it was not at all unusual to have at least a $5,000 and often a $10,000 deductible, that this would cost you upwards of $800 a month. It didn't cover all of the preventive care types of services that are required now under the ACA. So for example, no well baby visits, no well adult visits, no immunizations were covered by these policies. They were truly catastrophic policies. So it shouldn't surprise us on some level that Montana Blue Cross or the co-op in Montana or Pacific Source are offering plans which have many different combinations of deductibles and co-insurance rates of 10%, 15%, 20%. There you can get over 100 choices, and if you count across all 4 metal levels. And the Vice President of Pacific Source said to me, we know that people can't make a choice when there are that many choices. But it's pretty clear that they don't know what the price point is that people want, what combination of premium and cost sharing. There are no narrow network providers in Montana for obvious reasons, but for obvious reasons being there are only a little over 1 million people that live in Montana. But that's sort of if people are used to that, they're not so surprised by being offered essentially these catastrophic plans. But if you look at some other parts of like Texas, this is going to discourage them.
I mean, this is not entirely a function of what the insurers decided. The law actually has the silver plan at 70% coverage, which gives you basically a $6,000 out-of-pocket maximum And that was known in 2008 when they were writing the law, so it wasn't a shock to anybody. I think it goes back to this idea of pushing to the bounds of the envelope. Right. If the idea is that you only have X dollars and you want to cover as many people as you possibly can, and you have to decide where you put your money. Do you make the deductibles lower and then the subsidies have to be higher for the premiums? Or do you keep the deductibles high and put the money into the premium subsidies? And I think they just decided that this is the way to get as many people covered as they could.
Sherry, you had mentioned that the medical device tax and the employer mandate were the two most likely targets for repeal. I'm just curious what your thoughts, and I would open this up to the entire panel, what your thoughts are about the likelihood of repeal of the individual mandate. So my question really is twofold. There's a lot of saber rattling still about the individual mandate and how terrible it is. So what's the likelihood that it might be a target in the coming year, in the next session of the Congress? And secondly, how important is the individual mandate to the successful implementation of the law? 3 years ago it was considered to be absolutely crucial. Question is that still the case, or do you think the insurance exchanges can survive without it?
So I am pretty sure the president would veto a piece of legislation that repealed the individual mandate, which doesn't mean it won't happen, because I think that actually may increase the probability that it would happen because of the way that politics works, right? And the insurance industry would go completely ballistic. And I think it is important to realize that given the structure of the law, having the insurance industry go ballistic is not consistent with the continued operation of the system. So it's almost not an empirical question. It is as much about how the carriers would behave as it is about anything else. And I think it is really instructive to realize that the 3 national carriers didn't play until this year because they were too scared. Insurance companies don't like risk.
Support of the panel.
I wanted to ask if anybody has anybody studied the stigma effects of this, and if people are either the medical establishment or others are equating it with Medicaid? I mean, just quickly, my son happens to be on this, and he's reported to me twice that doctors have said to him, even though he's on the best plan, oh, you're on Medicaid. And I said to him, what's the point of them saying that to you? I mean, they're taking the insurance. So then it made me think, like, oh, there's a whole stigma, maybe, effect of this, and I don't know if anybody's looked into that. Or
Which state is he in?
New York. Yeah, I know. No? Nothing. Okay.
I was wondering about the future of the Consumer Assistance Program grants, in your opinion. Is there a lot of concern that people, even if they're newly insured, may not know how to use their insurance? They're not getting appropriate guidance on that, even that people might stop paying their premiums if they don't know how to use their insurance. Is this being addressed? Thank you.
So that's a really good question. So the first thing I want to say is that out of the roughly 8 to 8.2, whatever it is, million people who enrolled in a health plan in these marketplaces, something like 7.5 million have consistently paid their premiums, their share of the premiums since enrolling. And that is very good news for the insurance companies. It's part of why Aetna, Cigna, United Healthcare are coming into this marketplace. That is very good news because it stabilizes the risk pool. So the fact that they are paying their premium says to me that either a lot of them had health insurance at some time prior in their life and they know how to use health insurance, or they figured parts of it out. I also think a lot of them are relatively healthy. So that's one thing. Second thing is I think that this assister information to people when they were enrolling the first time of explaining what a deductible is, what coinsurance is, what a copayment is. There were a lot of questions that were being asked then, and I'm sure they're going to come up in this next open enrollment period as well. So, this again is one of those, we don't know, really. I haven't heard, but I leave it to the others. I haven't heard that.
Well, the only thing that I can add to this is that according to studies using the Health Reform Monitoring Study, 60% of people who are newly insured in the exchanges do have a usual source of care. And if you look at people who have had insurance in the long term, it's 80%. So there's still a difference, but it's probably a higher proportion that have this usual source of care than you might have expected with the brand new program.
We have a question from the webcast. How do you see the role of navigators and funding for their activities going forward, given that Republicans control the legislature? What is the evidence so far about them, and how will they evolve going forward?
I think the evidence is that navigators have been very, very important, and that the success of exchanges in different states has in many ways depended on how well the navigator programs have run. I can't say what's going to happen to the navigator funding going forward.
I mean, I think this goes back again to the point that Sherry just made, that the insurance companies would go ballistic if the individual mandate were overturned. They want these navigators and assisters to be helping people so that they get low-risk people enrolling in plans. They don't want it to just be an adverse selection problem.
So I have a measurement question. So I get nervous and concerned how we're going to measure the success of this. And one of the ways we do it is by the fall in the uninsured rate. And so you've rattled off some numbers. Next September, there'll be 3 estimates. They'll be really close. The levels will be close, but the changes won't be. CMS will have numbers. I'm sure New Mexico and every state. So is there a way we can convince policymakers to pick and stick? I mean, the changes should be, yeah, but how do we start that conversation so that people are prepared to say, here's what the effect was. It went from 45 million uninsured down to 38 million. I don't know what it's going to be.
Well, I think one of the questions has been, over what time period do we want to ask, do people have insurance coverage? And that we have sort of slowly been moving to a consensus on that we don't want it for the last 2 weeks, that we want it for a longer period of time. So I think in terms of that concept, that at least the different kinds of surveys are really trying to be more consistent, and so that when we do a comparison, we expect those numbers to be weighted and to be correct. I mean, one of the issues here, of course, is sample size and whether, in fact, for a number of groups, and we have reasonable numbers. And a lot of these estimates are from small samples, and so it would be nice to have this agreement. I don't know how quickly we're going to have that.
It didn't help that they changed the CPS question this year. Well, it was a good idea to change the CPS question, but this is not the moment that you wanted to break in the series. But that's true. But you would have liked to see... People shouldn't have been using the CPS, except we all did, so...
Well, I want to suggest also that there's some other very important measures, and this goes back a little bit to what I was saying about this being an incredibly significant economic development bill. I have, as it happens on our state insurance exchange, the various R's in legislature and governor's office appointed 2 different small rural hospital CEOs, each of whom came to this terrified that somehow we were going to do something that essentially ran them out of business because they're pretty marginal and pretty crucial to their communities. I would argue that we need some other, rather than just that sort of raw number that is across all kinds of places, a serious look at the extent to which we are keeping rural hospitals and small-town hospitals in existence, the extent to which we are seeing people in the healthcare professions able to survive, and even some beginning to move out to these areas, because all of a sudden, my God, there's somebody to bill. You're not taking chickens anymore, you know. And those are very significant and very important, I think, not only in the measurement of success, but also in the long-term view of this bill and of the idea that we actually should, finally join the rest of the developed world and provide health care to our citizens.
Hi. So this year we're going to have the first renewals, and I was wondering if maybe you could comment on how you see that playing out. So the way I understand it is people who enrolled in the marketplace are going to get a notice that they're up for renewal, and I think given past literature, many of them won't do anything. They'll just stay in their plan. They won't go to the website. They won't change anything. But with this group, there's a lot of volatility. So some people, their income might raise and their subsidy might change. And I'm not exactly sure how this is going to work out. But I guess I'm mostly concerned with those people whose income falls, and they might fall into the Medicaid gap. And what happens to them, and when do they find that out, and how does that work out? And I mean, I guess I'm a little worried about that because of the ill will that might form with people. The story told is a good example of that. So anyway, I was wondering if you could comment a little bit on how you see the renewals story playing out this first period.
My take on this is perhaps a little bit too much of an insider's take, because I'm just happy that we were not in the situation that we expected to be in, where, in essence, CMS and SOSIA were telling people, oh, you're just going to have to reapply from the ground zero again, which is where we were several months ago. That was the non-plan that existed at that point. So I'm pretty happy with the default that we're going to just put you back into the same plan. And that fits with, there's a fundamental principle, I think, that most of us who are involved in state regulation of insurance believe follows, and which is not true at the moment in the healthcare market. Insurance should be boring. It should be something you look at once every 3 years, decide if it's too expensive or if they've somehow screwed up your coverage or just been a pain in the neck, then you make a change. Otherwise, you look at it once every 3 years, and you don't look at it again for another 3. It should be boring. And, we are in this terrible situation where health insurance is not going to be boring for a very long time. But that is the goal. And so anything that can be done, I mean, honestly, the idea that, the second lowest silver plan changes, so everything about your costs just changed through no fault of your own because everything else stayed the same. Why should it change? It's kind of a nightmare, and there are endless supply of those kinds of nightmares involved in this. And I think probably if we had, any relatively normal political period where you could go back for technical corrections to a piece of legislation, these are the sorts of things that would actually get fixed. That's impossible right now, but that's kind of a solution devoutly to be wished for, and maybe somewhere down the road, as we keep on having 7 or 8 or more millions of people involved, eventually there will develop enough pressure to fix the things that are screwy like that, or like, what you're calling the Medicaid gap. We're lucky, thank God we did get Medicaid expansion in the state, so we don't expect to have, a nightmare there.
There was a question a moment ago about the stigma effect. I want to think about people in the exchanges. So in New York, apparently, some people who are getting health insurance through the exchanges and are sort of in the working poor category are signing up. But at least my physician reports that lots of his colleagues are not taking them. Is that an outlier because New York is so large, and is this happening or not happening in other large areas? Is that mythical, mystery? Can you say?
New York is really strange in terms of doctors not participating in insurance. It's not that it's so large, it's that there are a lot of really rich people. So it's possible to be a doctor in New York and make a living while not being willing to take insurance. There are not a lot of places in the country where that's true. It's certainly true also for the exchanges. People complain about it even in Medicare, which in most of the country, 95% of doctors across the country take Medicare. That figure is lower on the island of Manhattan. It's actually not as bad in Brooklyn. So if your friends are looking for a doctor, I suggest they look there.
I mean, this was brought up in Massachusetts as well, but I moved to Massachusetts in 1992, and it was hard to find a primary care physician then. And it's largely because Massachusetts has a high proportion of all physicians who are specialists. So, any lumping of difficulty of people finding a physician to take a plan through the connector right now, I think is really bogus. It has nothing to do with that.
Actually, there's actually been sort of secret shopper surveys that have been done now where they ask how many people are willing to take people. And even in Medicaid, the fraction of doctors across the country who are willing to take patients is actually not much lower than for private insurance. But there are places that are outliers.
There's a regulatory issue here, too. Some of the insurers have clearly signed separate contracts for this where they've said, oh, we want you to take our insureds from these qualified health plans on the exchange. Some of them found themselves very embarrassed when they discovered that they had to have the same plans off exchange, and they suddenly didn't have a way to make sure these people actually got care. But we're looking at this in New Mexico, and we're not entirely sure that, generally speaking, we don't tread into the contractual relationship between healthcare providers and insurers. It's generally we view that as like beyond the insurance code. But if it begins to affect the ability to cover people, to provide them with care, then it kind of begins to be in our turf. And so it's something we're looking at. We're very, we got some claims about this and why they couldn't do things they were legally mandated to do but you can't give away your legal requirements through, contractual actions. So we and our partners in the federal government, I say that with some amusement, simply told them, no, that won't do. You're going to have to fix that. But it is a problem, and it is inappropriate if they are contracting in that way.
So it looks like it's about time for us to wrap up. Oh, sorry.
I don't know if you guys can hear me. I just wanted to comment on the two, questions that just came up about the stigma and also physicians not wanting to take the expansion patients. I'm from Arkansas, so I have kind of a unique perspective on it. But as far as the cards go and the stigma surrounding that, the Arkansas Insurance Department actually mandated that Medicaid expansion patients, because they're, private option, they have to carry the private insurance card, and nowhere on it does it state anywhere that they're a Medicaid patient. So the physician's office actually won't figure that out until they get them in the door and see the patient. So that was something the Arkansas Insurance Department did to help that. And the Arkansas Insurance Department also allowed the insurance companies that provided plans on those exchanges to say that you are not allowed to participate in our other plans if you do not accept the expansion patients. And with because Arkansas has such a small insurance market, and plans like Blue Cross Blue Shield have such a huge market share, that would be detrimental for those providers to not be in network. So I just kind of wanted to comment on that from an Arkansas perspective.
Go Arkansas. I just copied that from Sherry. Let's join me in thanking our panel. Thank you for your very good questions, and we'll see you later.